Are you ready?
All right, we're going to go ahead and get started. I will hand over the controls to Dr. Nyack, who will introduce the webinar and our speakers. Thank you all.
Okay, welcome to this webinar. We have an exciting lineup of speakers who are prominent researchers in the field of pediatric trauma. My name is Bindi Naik-Mathuria. I'm an associate professor of surgery at Baylor in the Division of Pediatric Surgery and the medical director of the Level 1 Pediatric Trauma Program at Texas Children's. I'll serve as a trauma domain lead for the EMSC-EIIC, which is the Innovation and Improvement Center. Let me go ahead and introduce the speakers. Okay, could you help me advance the slides? I can't advance the slides. Somebody could help me advance the slides. I'm unable to advance the slides. Okay. Dr. James Holmes is a professor and vice chair for research in the Department of Emergency Medicine at UC Davis School of Medicine. His research is focused on the initial evaluation and treatment of injured patients, with a particular emphasis on injured children. He's had funding for his research from a variety of federal agencies, including the CDC, EMSC, and the NIH. He's additionally devoted much of his career to training junior investigators. He's a director of both the UC Davis Clinical and Translational Science Center's KL2 Research Training Program and the UC Davis Emergency Medicine Research Fellowship. Finally, he's been very involved in a variety of SAEM endeavors over his career. He currently serves on the SAEM Board of Directors. Next, we have Dr. Nathan Kupperman. He's a professor of emergency medicine and pediatrics and the Bo Thomas Profold Endowed Chair of the Department of Emergency Medicine at UC Davis. He's a pediatric emergency medicine physician and clinical epidemiologist. He's a leader in emergency medical services for children, particularly in multi-center research. He has several areas of interest in research, but his interest in pediatric trauma is focused on clinical prediction rules. He recently derived and validated a prediction rule for traumatic brain injury after minor blunt head trauma in more than 40,000 injured children. He also co-led a separate project to derive a prediction rule for intra-abdominal injury in more than 12,000 injured children. Dr. Kupperman has received more than $25 million in federal grants and contracts as a PI over the past decade. He's published more than 200 peer-reviewed publications and has been a leader in multi-center research in peds emergency medicine. He's one of the founding investigators of the PCAR network and also serves as the chair of the executive committee of the Global Pediatric Emergency Research Network, PERN, which is an international consortium of PEM research networks. And then finally, we have Dr. Julie Leonard. Dr. Leonard is an associate professor of pediatrics and pediatric emergency medicine at Nationwide Children's Hospital in Columbus, Ohio. She completed medical school, residency, and fellowship at WashU in St. Louis and is a board certified in emergency medicine. She practices medicine in the emergency department of Nationwide Children's Hospital and currently serves as the director of clinical research for the Center for Injury Research and Policy and the associate director for the Center for Pediatric Trauma Research at Nationwide Children's Hospital, which is in Columbus, Ohio. She's also a research collaborator in the Pediatric Emergency Care Applied Research Network, also known as PCARN. Dr. Leonard has published extensively in the area of cervical spine injury management and recently completed an NIH grant aimed at laying the groundwork for the development and implementation of pediatric cervical spine injury risk assessment tool that will be used for both pre-hospital and emergency department providers. So as you can see, we have a fantastic lineup today. Next slide, please. Next slide, please. Sorry, I can't advance the slide. Okay, so let's just discuss a few parking lot issues. The participants will be muted during the webinar, but you can ask questions you can post questions on the chat forum. An evaluation of the webinar will be sent after to all participants within a few days after the webinar. Feedback is welcome. And the CAPC, which is Commission and Accreditation of Pre-Hospital Continuing Education, credit is offered. To receive credit, you must complete and submit an evaluation that will be emailed to you with the email address that you used to register for the webinar. And with that, I think we're ready to begin.
All right, thank you very much. My name is Jim Holmes, and I'm an emergency medicine physician at the University of California, Davis, and I will talk about identifying children at very low risk of intra-abdominal injuries undergoing acute intervention. I have no financial conflicts to this talk. So our objectives will be to briefly talk about the epidemiology of blunt abdominal trauma in children, and then discuss the PCARN abdominal CT prediction rules, and then finally we'll end with talking about some of the future studies on abdominal trauma in children that we are doing. So as you're probably well aware, trauma is the leading cause of death in children over 1 year of age. Traumatic brain injury is the primary cause of death in most of these cases, though. Torso trauma, either to the abdomen or the chest, is the second leading cause of death, and maybe 5% of children with intra-abdominal injuries will ultimately die, but most of those still die because of concomitant head injury. When you look at preventable deaths and morbidity, those are due to airway obstruction or respiratory failure, secondary brain injury from an expanding intracranial hemorrhage, or either an unrecognized or undertreated intra-abdominal injury, and we'll try to focus on that today. Most mechanisms of injuries are motor vehicle collisions, auto versus pedestrians, or falls, and that definitely varies depending upon the age of the child. The spleen and liver are about equally injured, followed by the kidney, then the GI tract, and fortunately the pancreas is very uncommonly injured. Realize that many children will have more than one abdominal injured organ. So there are some controversies in the evaluation of children with blunt abdominal trauma, and that centers around the reliability of physical examination, the role of laboratory tests, utility of ultrasound in children, and these play a role in determining when to get CT scan. And realize that abdominal CT is the gold standard for identifying injuries, but it does have certain risks. And so when you look at abdominal CT in pediatric trauma, realize you should use IV contrast, but oral contrast is not necessary. And there are multiple studies now that support that both in pediatric and the adult population. It has great sensitivity for solid organ injuries, and it now has good sensitivity for gastrointestinal injuries. Years ago, that used to be considered a problem for CT scan, gastrointestinal injuries, but now the newer generation helical CT scanners have sensitivities over 95% for gastrointestinal injuries. However, CT continues, even the new generation helical CT scanners, they continue to have problems in identifying children with pancreatic injuries with a sensitivity, even of the new generation helical CT scanners, only around 50%. So you might say, well, we could just CT everyone, but there are some downsides with CT. This is a slide here shows the estimates of the risk of getting a cancer from CT scan, and it's stratified by the gender of the patient as well as the age of patient. And you can see girls have a little bit higher rate of getting a cancer following a CT than boys, and the younger children have a little higher risk than older children. But realize approximately 1 in 350 girls that have an abdominal CT between the ages of 0 to 14 will ultimately get a cancer. Similarly with boys, it's roughly 1 out of 725. Realize that this Cancer doesn't occur for 20 to 25 years later, but these are the rates. So there are reasons to avoid CT if it's not necessary. So people have attempted to look at decision rules for abdominal CT use in children after trauma, and here are a couple of the studies that have been out there, but they've been limited by their small numbers or single sites until the last one, and that's the one we'll focus on today, and that's the PCARN study. So the PCARN abdominal injury decision instrument, we published this almost 5 years ago. It is to derive a clinical prediction rule to identify children with blunt abdominal trauma who are at very low risk for intra-abdominal injury undergoing acute intervention. We enrolled children as they presented to the emergency department for just over 2.5 years, and it was children less than 18 years of age that had blunt abdominal trauma. We excluded children with penetrating trauma if their injury was more than 24 hours old, and then some additional exclusions that were quite minimal. We importantly recorded the data on their presentation to the emergency department prior to the abdominal CT scan being performed. And that's important to avoid any bias with knowing whether or not the child had intra-abdominal injury when you complete the data form. Follow-up was obtained on all patients enrolled. For those that were discharged from the emergency department, we called their guardian by telephone, and for admitted patients, we reviewed their medical record to see what happened to them while they were hospitalized. Our primary outcome when we were modeling our decision instrument is intra-abdominal injury undergoing acute intervention, and these are the 5 findings that would make an intra-abdominal injury undergo acute intervention. That is, they died from their intra-abdominal injury, they underwent a therapeutic laparotomy, they had an angiographic embolization of a bleeding vessel in their abdomen, they received a blood transfusion for abdominal hemorrhage, or they were held without anything by mouth to eat or drink for 2 or more nights in those patients with gastrointestinal and pancreatic injuries. The vast majority of patients met either therapeutic laparotomy or a blood transfusion for their abdominal hemorrhage. We ultimately, over the 2.5-year period, enrolled 12,000 patients. 761 of them had intra-abdominal injuries, but 203 of them had intra-abdominal injuries undergoing an acute intervention, and that is our outcome of interest and what we attempted to identify those variables that identified patients with that finding. Of note, we created a decision rule, but that decision rule has yet to be validated, and we'll talk a little bit more about that shortly. So this is the decision rule. It goes from abdominal wall trauma there at the top all the way down, and you can see the high-risk variables here on the left. So abdominal wall trauma, GCS score less than 14, abdominal tenderness, thoracic trauma, abdominal pain, decreased breath sounds, or vomiting. If they had none of these variables, there were about 5,000 patients. 25% of those patients still underwent CT scan. Of note, of these 5,000 patients that had none of the decision rule variables, 6 of them still had intra-abdominal injury that underwent acute intervention. So you probably ask, well, what was the situation with those cases? These are those 6 cases. I will point out the last 4, the 16-year-old and the 3 17-year-olds, were all enrolled from the same site, and we have a little concern about the data just because we reviewed those cases and they were classified as having, say, a normal mental status, despite the fact that they some of them were intubated, some of them had GCS scores recorded as 10 or 11, and then the 2-year-old with increased LFTs and a liver injury and a GI injury was the victim of abuse. And so you never know if that is the timing of that particular injury. And we generally do not believe that these decision rules should be applied to children with abuse. So this is how we recommend utilizing this particular decision rule. You can see that upper left box, evidence of abdominal wall trauma or seatbelt sign or a GCS score less than 14 with blunt abdominal trauma. The risk of an intra-abdominal injury undergoing acute intervention is about 5.7%. So fairly risky presentation if they have those findings. In general, further evaluation is definitely needed in these patients, and strongly consider abdominal CT, but not necessarily mandated. You can do some observation and screening, and we'll talk about ways to screen these patients here shortly. If they don't have either of those variables, but they have moderate or severe abdominal tenderness, that risk is about 1.4% of intra-abdominal injury undergoing acute intervention. Again, abdominal CT versus observation with some ancillary testing, and we'll talk about that ancillary testing here in a second. And then finally, the last variable, thoracic wall trauma, abdominal pain, decreased breath sounds, vomiting, or mild abdominal tenderness. That risk is less than 1%. Again, observation is recommended in this population, probably some screening with laboratory tests or the FAST exam, but again, we'll talk about that in just a second. But the important thing to remember is they do not have any of these variables. That was about 42% of the population, 0.1% risk of intra-abdominal injury. CT is generally not recommended in this patients because their risk of injury that needs therapy is so low. So I talked a little bit about screening these patients with laboratory tests. That is, if you have maybe thoracic wall trauma and complaints of abdominal pain, maybe you want to observe the kid and screen them with laboratory tests and do serial exams. This is one of our studies that looks at what are the most important independent laboratory tests, and we enrolled 1,000 children, of which 107 had intra-abdominal injury, and the three most important laboratory variables were elevated liver transaminases, hematuria, or hematocrit less than 30%. Of note, just because the hematuria, the patient has, say, more than 5 red blood cells per high-powered field, it doesn't mean that they absolutely need a CT scan, but it does mean that they are not at low risk. We also looked at the FAST examination. This was a PCARN study that we did in conjunction with the study I just talked about. We had 20 sites. FAST was only used in about 14% of children with blunt torso trauma. And we stratified kids based upon what the clinician thought was the risk of intra-abdominal injury. And then we looked at the rate of abdominal CT use in patients that had the FAST exam performed. So this was an observational study, and this is what we found. When the clinician thought that there was a significant risk for intra-abdominal injury, either from greater than 11% risk of intra-abdominal injury, doing the FAST exam here in this column, they had relative risks of 0.99 and 0.97 of undergoing CT scan. The FAST exam had little to no impact on whether or not they got a CT. And that makes sense because the FAST exam does have some limitations, including limited sensitivity. So if you think the patient's risk is substantial, a negative FAST exam is probably not good enough to alleviate a CT. However, when you look at the risk group from 1 to 5% or 6 to 10%, that is, clinician thought the child had a 1 to 5% risk of intra-abdominal injury or a 6 to 10% risk of intra-abdominal injury, that is where the FAST exam made a difference. The abdominal CT, rate of abdominal CT was decreased in both of those two groups between 15 and 19%. That is, they had relative risks of 0.81 and 0.85. So they statistically decreased CT rate when they used the FAST exam in those children that were low risk. Now, this was an observational study, and so we thought we should probably do a randomized controlled trial to see if those findings held true in a randomized controlled trial. We just published this almost a year ago in JAMA. It's a randomized controlled trial that Nate and I did at UC Davis, so it was only at one center. We had 925 children, 460 of them randomized to FAST exam, 465 randomized to no FAST. The FAST was done by the treating clinician, and then we just followed those patients to see what happened to them. As you can see, the randomization was fine. The two groups were similar with regards to age, gender, initial GCS score, pediatric trauma score, rate of abdominal tenderness, the rate of intra-abdominal injury, and the rate of hemoperitoneum on CT scan. So the two groups were adequately randomized. These are our outcomes, and we looked, I will point out that the first one, abdominal CT, that was our primary outcome. And you can see in the FAST group, 52% underwent CT, and the no FAST group, 54%. So a slight decrease, but that was not statistically significant. Similarly, there were no other statistical differences in our primary outcomes in the group that got randomized to the FAST exam. Interestingly, what we did find in this is that the clinicians actually changed their opinion about their risk of intra-abdominal injury in this population. So although it didn't change the rate of abdominal CT, laparotomy, hospitalization, time to CT, time to ED disposition, or hospital length of stay, clinicians, after performing the FAST exam, then said that child was at a significantly lower risk of having an intra-abdominal injury. And this makes sense because after you perform a FAST exam that's normal, you probably believe the child had a lower risk of intra-abdominal injury. Unfortunately, that did not translate to abdominal CT, and we're investigating on why that happened. And finally, let me just talk about a couple of future studies. We are currently validating the PCARN abdominal injury decision instrument right now. We're doing it in 6 centers, and we're going to enroll approximately 100 patients with intra-abdominal injury undergoing acute intervention. And Nate and I hope to have those results here in a couple years. And then finally, we're putting together a multi-center study on the FAST examination in children to see if that can safely decrease CT scan. It will also be a randomized controlled trial at 6 centers of about 3,000 children, and we plan to submit that grant this summer. So thank you very much.
Great, thanks, Jim. I'm assuming everybody can hear me okay, and this is Nate Kupperman, and I'm gonna talk about head CT prediction rules. I'm gonna focus, and I'm gonna speak a little quickly to make sure Julie has her time, but I'm gonna focus on how we have generated evidence around CT decision-making, and then the science around implementation of these head CT decision rules. So let's see. Can someone advance the slide, because I'm trying here and it's not advancing? Thanks. And I have no conflicts of interest to disclose. Next slide. So the objectives, I'm just going to speak very briefly about the epidemiology of head trauma in children. I'm going to review the PCARN head CT prediction rules, how we derived and internally validated, and then how PCARN has translated the CT rules into practice. Next slide. So I just want you all to kind of put this case in your mind, and we'll get back to this in a few minutes, but it's an 8-month-old who falls a few feet from a carrier, has a momentary loss of consciousness and 1 episode of emesis. On exam, the the infant's acting normally and has a small forehead hematoma that's tender at the site. And what are you going to do with this scenario? And I will guarantee you, for this scenario around emergency departments in this country, some will CT, some won't. There's a lot of variability. Next slide, please. So just sort of one slide about the epidemiology, and it's reiterating some of the things that Jim had mentioned about trauma, of course, being the leading cause of death among children older than 1, and TBI is the leading cause of death in trauma, about 70% of deaths due to trauma. And you can see the numbers there. On an annual basis in the United States, blunt head trauma results in 6,000 deaths, 60,000 hospitalizations, and about 2/3 of a million ED visits. And the estimates of the percentage that result in CT scans varies from 30 to 50%, depending on the database you use and what you believe, but somewhere in that range. Next slide. So this is the controversy over CT in minor blunt head trauma. Here are the arguments for liberally using CT. We know that a lot of patients with positive CTs come in with normalish GCS scores, and they look pretty good, but you'll sometimes find previously unrecognized TBIs. We know that preverbal children are difficult to evaluate, and so you can argue why not pass them all through the scanner. And we actually know that CT is great technology. That is, when it's indicated, the benefits greatly outweigh the risks. However, next slide, please. These are the arguments against liberal use of CT. We know that of the large number of children with minor blunt head trauma that we CT, fewer than 10%, it's actually about 5% will have TBI on CT. The drawbacks include, frequently you're transporting these children outside the ED. Some require pharmacological sedation. I can tell you that number based on the PCARN data. Now it's only 3%, so it's not a big number. Require pharmacological sedation, and there are costs involved. But as Jim mentioned, the biggest risk is the risk of lethal malignancy from a single current generation CT scanner, and it can be as high as 1 in 2,500. And this topic of CT in blunt head, blunt abdominal trauma, it's high priority for EMSC, the National Academy of Medicine, and other important bodies. So just another word or two about CT radiation risk. These are estimates that are from the horrific events of World War II and survivors of the nuclear weapons in Hiroshima and Nagasaki. And by extrapolation, the risks are about 1 per 2,500 head CT scans for a 5-year-old and 1 per 5,000 in a 10-year-old. And for abdominal CT scans, as Jim implied, but just to put a relative number to this, you just basically double the risk for abdominal CT scans. Next slide, please. And if you look at CTs done, if you could back that to the previous slide, CTs done for any reason in the United States, there's about 6 million pediatric CTs annually. 300,000 of those are for blunt head trauma. So if we could just lower that 6 million by 1 million, the implications in saved cancers is quite substantial from a public health point of view. Next slide, please. So this is what we have done in PCARN. Here's a slide of a bunch of PCARNers that we were a lot younger then because we've been at the PCARN business for 17 years. Next slide. So you can see PCARN is a network that we don't do disease-specific research. We do research in a number of areas, but we've done a lot of research in trauma, head, abdominal, and C-spine, as Julie will talk about next. And in the bold, I'm just going to highlight 2 big studies, the generation of the head CT decision rules and the knowledge translation studies around those rules. Next slide, please. So the goal of the PCARN head study, really important, was to derive a decision rule to identify children at near zero risk of having a clinically important traumatic brain injury after blunt trauma with really high accuracy, great precision, and wide generalizability. Again, to identify those that are at low risk who do not need scan, the goal was not necessarily to identify those who do need CT scans. Next slide. Our outcome was very purposeful. It took several months to come to this outcome, consensus amongst many investigators of different disciplines over several months. But the clinically important TBI was defined as the death from TBI, the requirement of a neurosurgical procedure, intubation for at least 24 hours for the head injury, or a positive CT scan that was associated with hospitalization for 2 or more nights because the child was symptomatic from that positive CT. And importantly, we picked this particular outcome because as technology changes from CT to MR to PET scan, this outcome still is an important outcome measure. Next slide. And this is a quick schematic, and you can see my arrow. There were 57,000 eligible patients, but we only enrolled those with GCS scores of 14 or 15 because if you have a GCS score of 13, the positive CT rate is about 20%. That child needs a CT scan. We enrolled 42,000, and we missed 11,000, but those 2 groups were identical in rate of CT and rate of CT positivity. Of the 42,000 enrolled, we derived our prediction rules on about 34,000 and validated on about 9,000, and you can see the rate of clinically important TBI about 1% in each of those 2 groups. Next slide. This was published in Lancet a few years ago. Go ahead and next slide, please. And I want to just highlight a few things. These are animated slides. So there's the rule for the under 2 years and the rule for 2 to 18 years. And 3 of the variables look similar. Severe mechanism of injury, go ahead, and then actually altered mental status, which was a GCS of 14 or other signs of altered mental status. 1 second, please. The other variables are different between the groups, but I wanted to point out that there are two of the factors that are high-risk factors, and those are altered mental status, that is GCS of 14, or other signs of altered mental status, or signs of skull fracture, a palpable skull fracture in the younger than 2, or signs of basilar skull fracture in the older than 2. Those are the two high-risk factors. The other, we call those sort of intermediate risk factors. And again, the goal of these rules is that if you don't have any of these factors, your risk of having a clinically important traumatic brain injury is very low. Next slide, please. So if you kind of summarize this is for children younger than 2. If you don't have either of those two high-risk factors and none of the 4 intermediate risk factors, that's more than half of the population, and your risk of a clinically important brain injury is less than 1 in 5,000. If you could advance, this is an animated slide. But if you have either of those high-risk factors, it's about 14% of the population with about 1 in 20 to 25 risk of a clinically important TBI, we would say to CT. But if you have one of those intermediate risk factors, those patients, many if not most of them, could be observed rather than CT based on a number of factors that you see there. Next slide, please. And this is the similar figure, but for children 2 years and older. Again, if you have either of those two high-risk factors, about 14% of the population. If you have neither of those or neither of the 4 intermediate risk factors, it's about 60%, 57% of the population, and they have less than 1 in 2,000 risk of traumatic brain injury. Next slide. For those with either of those two high-risk factors, we would recommend SCT. It's only 14% of the population. And for those who have one of the intermediate risk factors, we would greatly recommend observation. Next slide, please. This was one of the sub-studies. We published a lot of sub-analyses from these data, and this shows that for clinicians who followed a strategy of observing the child for a number of hours before deciding on CT, obtaining of CT, it cut the rate of CT in those patients by 50%. Next slide. And we also published a series, of course, I'm not going to walk you through each of these, but these are all very similar studies. We identified what the risk was if you just had one of those intermediate risk factors in each of these groups. So, and you can see them. These are intermediate risk factors: severe mechanism, vomiting, isolated headache, isolated LOC. And the bottom line is if you have any of those intermediate risk factors in isolation, your risk of a clinically important traumatic brain injury is somewhere between 1 in 200 and 1 in 400. Next slide. So how do we take this great amount of evidence and information and implement it into practice? Next slide. So knowledge translation, you can see the definition there. It's the effective and timely incorporation of evidence into practices of health professionals so to affect optimal healthcare outcomes and maximize the potential of the health system. This is modified from the Canadian Institutes for Health Research. Next slide's an animated slide. Importantly, you need to know when you have definitive evidence that's ready to be implemented. That's very important. Next slide. So this is actually one of my favorite slides. This is from Glasgow and Haynes. These are some of the grandfathers of evidence-based medicine. And this is sort of the evidence to implementation pyramid. So this pyramid represents accumulation of evidence from primary studies, systematic reviews, synopses, and you gather this mountain of evidence, and then you've got to get that evidence to the patient over here. The problem is you encounter lots of obstacles. There's myth and opinion and poor research out there that blocks your way, and lots of other obstacles that you can see here that you can attempt to overcome through bedside evidence-based practice, quality improvement initiatives, decision aids, but you want to keep that pipe full of water so that the patient gets the best evidence to the bedside. Next slide. So how do you do that? Well, one way is you can do sort of pocket cards, and this is California ACEP. They created these pocket cards on the PCARN head decision rule and distributed it to many thousands of its members, and those are used widely. The problem is, of course, none of us have enough pocket space for all the decision rules out there, so that's not an efficient way to do it. Next slide. So if you kind of summarize what really works when translating research into practice, this is one of the seminal articles on the topic. Kawamoto did a systematic review on this, and these are the 4 factors that were associated with successful implementation of evidence. And that means those were automatic provision of the support in the workflow in the ED. Clinicians in general like recommendations rather than risks. They want to be told, get the CT or not. It needs to be given at the time and the location of the decision making, and it has to be in the computer because that's at the point of care. Next slide. So what PCARN did, because we've just published the study, next slide, we implemented the PCARN TBI decision rules using electronic health record-based clinical decision support. It was an interrupted time series trial. Next slide. This was just published very recently, several months ago. Go ahead, next slide. And the goals of the study were first to develop and test a computer-based system to see if we could implement the rules, and secondly, to determine whether when you implement the rules, it results in lower head CT use. Next slide. Before we did the study, this took many years to do, but we did focus group work. We went to all 13 EDs that were participating in the study to look at how they use the EHR and the computer in the assessment of children with head trauma. We then developed the head injury template, the decision support, and pilot tested it before we did the trial. Next slide. And this is what the template looks like. These are the 12 variables of the PCARN rule, and it takes you 20 seconds to click on whether the patient has any of these factors, and this is animated for one slide, if you could advance that. If you don't remember what one of the factors is, like what does altered mental status mean, you can click on the icon and it gives you the PCARN definition. Next slide. So if we go back to that case that I was telling you about, the 8-month-old that falls 2 feet from a carrier, momentary LOC, an episode of emesis, acting normal, and a forehead hematoma. Next slide. You would punch those factors into that spreadsheet in 20 seconds, and this is what comes up. A head CT is not recommended based on the absence of any of the prediction rule variables for that age group, and we also give the risk. That is, we give a recommendation and the risk. The risk for this child is less than 1 in 5,000. Next slide. So when we tested this in a time series trial, and this was conducted over a couple of years, pre-intervention phase, the intervention in which we provide the decision support, and then it was maintained. We looked at CT rates before and after, and then we had a couple of control EDs to monitor secular trends. Next slide. Here were the results of that study, and then I will turn it over to Julie. First of all, this is for children who were at very low risk, that is, children who have none of the PCARN risk factors. The baseline rate of CT use was already low because there had been probably a lot of diffusion of knowledge around PCARN already. But with the decision support, we lowered it a little bit, and it was statistically significant. Next slide. This is interesting. These are all comers, not the low-risk group. These were all patients who met PCARN criteria to be studied, and their baseline rate of CT use, about 20%, but after the intervention, lowered to 17%, on highly significant decrease. And the last slide of this study, I'm almost done here. And this is a really important slide because people speculated that, people might misinterpret the rule to say if you have one of the factors, they'll get the CT scan. Well, these are patients that have at least one of the PCARN risk factors. And before the intervention, their rate of CT was 36.5. Afterwards, their rate also decreased not significant, but we did not see an increase in CT rate as many speculated we might. Next slide. And finally, the really important message is that just producing the evidence by itself won't necessarily impact change. You then have to implement it. So there's two examples. This was done at Boston Children's, led by Lise Nigrovich, who implemented the PCARN CT rules. They had a baseline rate of CT use of 21%, but after implementing the rules and then also providing individual provider feedback, the CT rate decreased to 9% there. And the next and final slide, a similar study conducted in a community ED where the baseline CT rate was 29%. They implemented the rules with this decision support and provider feedback, and their CT rate down to 17%. So the bottom line is that the evidence is very powerful, and once the evidence is implemented with appropriate decision support and quality improvement initiatives, you can bring those CT rates to rates that are as low as in other countries that have low CT rates, but we are doing it with evidence rather than clinician gestalt. And I think that's my last slide. Thank you very much. I'll turn it over to Julie.
Great, thank you, Nate. So I'm going to be talking about the emergency management of cervical spine injury and assessing children for risk of cervical spine injury. I have no financial disclosures. Just briefly, our objectives are to discuss the potential adverse effects of using a rigid long board and cervical collar for trauma transport, to define some factors that can aid identification of children that might be at risk for cervical spine injury and who may benefit from either interventions in the field or from imaging in the emergency department. And then finally, to discuss best practices for imaging children for cervical spine injury. So unlike abdominal trauma and head CT, there's actually interventions that go on in the field that affect outcomes of patients when you're concerned about cervical spine injury, and that's the practice of spine immobilization. So spine immobilization, and this is data from the early 1990s when adult decision rules for cervical spine injury were being derived, and at that time, they estimated that more than 1 million individuals were being immobilized per year, and that the costs associated with that were somewhere around $440 per patient. And this was the cost of the trauma interventions in the field through their ED care and imaging. And if you imagine moving those dollars forward 25 years to this day and age, now it's estimated that up to 8 million individuals are undergoing field evaluation and immobilization and transport to trauma centers. And dollars have more than doubled. So it's estimated that it's around $2,500 per patient to put them through this process of field immobilization. And then if you use CT imaging to clear their spine of injury in the emergency department. So you have to ask yourself, why are we doing this? And that is because cervical spine injuries are a very morbid condition. So in children, the death rate from cervical spine injuries are 7.4%. And children that have these injuries are likely 1 in 4 will have a permanent neurologic deficit that they'll live with. But on the other hand, you juxtapose that against the estimated incidence of cervical spine injury in the population, and it's relatively low. So for adults, it's estimated that among trauma evaluations, about 2.6 to 2.7% of adults will have a cervical spine injury. But in children, it's much lower. If you look at prospective observational studies that were conducted in general EDs, it's probably less than 1% of the patient population presenting to general EDs for assessment following blunt trauma. And then if you look at quaternary emergency departments is higher. It's probably around 1.7% of children that are presenting for trauma evaluation. So the problem that we have is that, can you please advance the slide? The challenge that we have, next slide please, is that to date, while we have adult decision support rules, there has not been a prospectively derived and validated decision support tool for children. And in the PCARN consortium, using a retrospective cohort, we were basically able to demonstrate, in the absence of having a decision support tool, that children there's a high variability of practice in terms of who's being provided spinal precautions in the field and who are not. So this slide actually illustrates the proportion of children with cervical spine injuries in a large cohort of injured children who actually had spinal precautions for trauma transport. And all of these children actually had cervical spine injuries. And what it demonstrates is that in very young children, only 40% of those children were identified in the field for needing spinal precautions and being at risk for cervical spine injury. And then as children aged up towards adulthood in the 8 to 15 year age range, only 80% of those children were identified in the field as being at risk for cervical spine injury. So not only is it widely practiced, but we also are not actually able to identify those children that are at the greatest risk. So we have a twin problem here. We're not doing a very good job of identifying those children that have injuries, and we're very indiscriminate, meaning we're applying an intervention to a wide range of children that are at much lower risk. Next slide, please. So the harms are enumerated and have been enumerated over the past 30 years of the practice of immobilizing children in the field. So, the whole concept behind providing spinal precautions in the field is that movement of the patient might worsen a neurologic injury or induce a neurologic injury if you have an unstable cervical spine. But unfortunately, there's no evidence to date that actually supports the idea that spinal precautions in the field actually improve neurologic outcome. And in fact, there's some retrospective literature that suggests that it's quite the opposite. It actually worsens outcomes. But if you put aside the idea of benefiting the patient, there are substantial harms associated with that. And there's, most important, if you were going to provide an intervention aimed at helping those that have neurologic injuries and the sickest of the sick, then you would hope that you are putting them in a physiologic position that would benefit their injury, and that it wouldn't cause any kind of worsening of their critical status. But in fact, what the literature shows is that spinal precautions put you in non-physiologic positioning, that you have worse outcomes from airway management and ventilation, that if you have a head injury, that being placed in spinal precautions actually increases your ICP, and that, in fact, if you are obtunded and you're laying on a rigid surface for prolonged periods of time, like on a rigid longboard, you have a higher risk of developing pressure ulcers, and that risk is actually directly attributable to the length of time that a patient's laying on that rigid surface. So it hasn't been able to be demonstrated as a positive thing for those patients that are the most critically ill and perhaps at greatest risk for cervical spine injury. But on the other hand, for those that are well, it actually is causing some harms to them as well. And the two greatest of these that we've been able to demonstrate is that children that undergo spinal precautions in the field have increased pain, and that when we receive those patients in the emergency department and they have increased pain and they have spinal precautions in place, that our tendency is to use imaging more often to actually clear them of cervical spine injury. Next slide, please. So this is a study that actually demonstrates that. This is a single-center prospective observational study that was conducted at St. Louis Children's Hospital. And basically, we prospectively enrolled children who arrived for trauma evaluation, and we compared those children that had spinal precautions placed prior to evaluation in the ED to those children that would have or should have met the current ACS guidelines at the time for spinal precautions, but arrived without them. And what we were able to demonstrate is that there was a twofold increased risk of a higher pain score if you had spinal precautions in place, and an eightfold increase in your cervical spine imaging if you actually had spinal precautions in place. And so again, laying that groundwork for the fact that that intervention in the field is actually affecting their downstream care once they arrive at the emergency department. So the need to be much more discriminatory, in the field, even prior to making the decision to image them or not in the emergency department. Next slide, please. And to further support that information that what's happening out in the field actually influences what we do in the emergency department, we took a look at comparing whether or not ED providers or EMS providers were assessing children neck exams. And this is findings from a prospective observational study that we conducted at 4 PCARN centers. And basically what we were able to demonstrate is that ED providers would frequently defer their assessments of neck range of motion by both history and exam if a child arrived in the emergency department in spinal precautions. And in fact, in subsequent information I'm going to present, that's one of the key findings of determining whether or not a child is at risk for a cervical spine injury is the ability to freely range their neck. And in fact, if they're coming and they've already had a collar placed, ED providers are not reassessing them for that finding. They're just deferring to what was occurring in the field. So again, the concept that what happens in the field is actually affecting what we do in the emergency department. Next slide, please. So I'm going to just also point out that while Nate started to get at that we're in a current period of time where CT rates are starting to drop, there's 2 areas that they aren't, and one of them is cervical spine CTs. So this is a study that demonstrates that between 2000 and 2006, the use of cervical spine CT in children in pediatric emergency departments increased by 366%, again, because we don't have a derived decision rule. Next slide, please. So why worry about CT of the neck? And again, you've heard from all 3 of the speakers about the risks of radiation in children. So the biggest risk in children is irradiation of the thyroid, and there's a couple of reasons why it's more important in children than adults, and why the literature regarding tumors in medically induced tumors diverges. The first is that there's a 10-fold increase in experienced irradiation in children when it comes to the thyroid. So it's very much dependent on age and the imaging technique and gender. But the thyroid in children is very metabolically active. You have an iodine effect. And the size of the thyroid relative to the surrounding tissue in children is much larger. So as a result, they experience a 10-fold increase for the same scan when compared to adults. And not only that, they have their lifetime to experience or that induced tumor. Next slide. So this actually, it's an older study, but it's not based on Hiroshima and other radiation exposure, mass exposure data. This is actually a study that showed serial irradiation of children in childhood. This cohort, at the time they did the study, was in their 40s, but all of these individuals had received serial x-rays of the neck in an attempt to shrink thyroid tissue, lymphoid tissue. And so they were able to look at this cohort and calculate cumulative doses during their therapy. And they were able to demonstrate that basically the cumulative dose range in this cohort was very similar to what a CT dose range would be. And in this cohort, 1 in 9 developed thyroid cancer and 1 in 3 developed a nodule of any type. And the risk was highest in those children that were irradiated before the age of 4. And as you reflect back on that initial slide I showed you, those are the kids that we are the least comfortable in terms of evaluating them for potential injury. Next slide. So we have this cascade of events where EMS is evaluating children. We don't have criteria that have been derived and evaluated. So they become immobilized, transported to the ED. We have limited tools available to us in the ED for evaluating children. So we rely on imaging, and at an increasing rate, rely on CT imaging. So we have this longitudinal effect that's going on. Next slide. So within PCARN, next slide please, have undertaken the serial steps to develop a decision support tool. So the first step was to conduct a case control study, which we conducted among 17 medical centers over a 5-year time span. The cohort had 540 children with cervical spine injury, so this was the largest assembled cohort of children with cervical spine injury. And we compared them to 3 different control groups to see if we could find risk factors that would help us differentiate between children with cervical spine injury and those that had been imaged but were free of cervical spine injury. Next slide. In this study, we actually found these 8 factors that we found to be highly associated with the children that had cervical spine injury. So altered mental status, focal neurologic findings, the complaint of the child of neck pain, torticollis, substantial comorbid injury to the torso, so that was a surgical injury to the torso, or a predisposing condition such as Down syndrome, high-risk motor vehicle collisions, so those motor vehicle collisions that meet the CDC criteria for high risk, and then children that had diving or head-first axial load injuries. And these factors were actually nearly 100% sensitive for cervical spine injury in our cohort. And the children that did not get picked up by this rule, when we went back and reviewed the medical charts, while we didn't find explicit documentation of these risk factors, given the constellation of other findings, it's likely that the patients had one of these findings but did not document it. And furthermore, it was 26% specific for cervical spine injury. And the way to take that number is basically, this was a cohort that all of them had been imaged. And if we had used this tool or this rule as a retrospectively derived model as a rule, we basically would have been able to eliminate a quarter of the imaging that was obtained within this retrospective cohort. Next slide. So then we took the effort to start to lay the groundwork for a large prospective observational study to derive and validate a decision support tool. And we've conducted this at 4 freestanding quaternary children's hospitals. And we enrolled children that either were transported in spinal precautions, had a trauma team evaluation, or cervical spine imaging ordered. And we collected data from both ED providers and EMS providers, and then followed them serially to see what their outcomes were. And in this cohort, we had 74 children that had cervical spine injuries. Next slide, please. And we were able to demonstrate, though the sample size in this limited pilot study for our larger prospective observational study that we're embarking on, we were able to demonstrate that those retrospectively identified factors actually performed pretty well prospectively in identifying children that had cervical spine injury, but also had good specificity as well. So in this cohort, the sensitivity using these factors for cervical spine injury was 90%, and the specificity was 46%. So again, the capacity to substantially decrease our imaging. And then when we looked at the 10% of children that would have been missed using these factors, again, we relied on physicians that were bedside caring for the patient. And when we went back and looked at the medical charts, all of the patients had one of these factors documented by some physician in the medical record. So that awareness and that education among physicians that these are factors that you need to be looking for. Because when we actually ask them bedside after they examine the patient, again, if a lot of these findings they weren't routinely assessing for. Next slide. So how can you use these at this juncture when we're in a phase where we haven't completely derived and validated a tool? Next slide. Basically, it's the best evidence to date of risk factors that can be incorporated into guidelines and then paired with what we know about the adult literature. So this is an example of a suggested example guideline that can be used for spinal immobilization, where you only use a rigid long board for those patients that are at high risk, meaning they're unconscious or they have a focal neurologic deficit, or you need the rigid long board to extricate the patient. And then for those that have more intermediate risk factors for cervical spine injury, they're placed in a collar and they're transported using NHTSA guidelines for safe trauma transport. Next slide. And again, this is another example. The Ohio EMSC Medical Directors Conference, they were deriving some different protocols for agencies to use. And again, how they elected to pull in use of these retrospectively identified factors as a guideline because they're not established yet as a decision support rule. Next slide, please. So the idea of using these risk factors and to start to limit spinal mobilization is starting to now permeate into national guidelines. So the American College of Surgeons Committee on Trauma, the American College of Emergency Physicians, the National EMS Physicians, and forthcoming, the AAP and the American Nursing Association, all are coming up with statements that use these factors to start to restrict the use of spinal motion restriction precautions in the emergency setting, in the pre-hospital emergency setting. So it's starting to permeate and is acceptable practice to use these factors to start to develop field clearance guidelines. Next slide. I think we're at, Mindy, at this time, we're kind of running out of time. Should I finish these last few slides?
Yes.
Okay. Just briefly on the utility of plain radiographs. In the large retrospective cohort of injured children, we were able to demonstrate that plain films alone were able to detect 90% of injuries. And the injuries that can be detected on plain films are fractures and ligamentous injuries. But things like spinal cord injury or SIWORA, atlantoaxial rotatory subluxation, those are injuries that by definition you can't use plain films on. And then when we looked at the patients that were missed, there were kind of two groups of patients. There were patients that did have significant injuries that in a likely in a decision rule, we would recommend that they would have gotten CT. So there were patients that had altered mental status and were intubated and had focal neurologic deficits. And then the other half of the children were children that had injuries that were minor and did not need intervention. Next slide. So just some brief comments on summary of the literature in CT versus MRI. So CT remains superior to MRI for fracture, and MRI remains superior to CT for soft tissue injury and hematoma. But with newer technologies, there's near equipoise between these two modalities, and so your choice really depends on the clinical scenario. Next slide. So in general, CT should be considered for use for children that have moderate to severe traumatic brain injury because their risk of cervical spine injury is high and the risk of missed injury is high. And children who have focal neurologic deficits on exam that can be attributed to the spinal cord should also undergo CT as a first modality. And then, of course, if you identify an injury on plain films, it's often the next step after neurosurgical or orthopedic evaluation. Next slide. MRI really should be restricted to those patients that have findings on imaging, and it's the next step recommendation, or children with persistent neurological deficits that are attributable to the spinal cord and your CT is negative. Next step. And again, this is how at Nationwide Children's we've actually used the retrospectively identified PCARN risk factors to inform our imaging algorithm. So at our institution, we use CT for all patients that have a GCS of 3 to 8. And if they have a persistent GCS of 9 to 13 or are intubated, then we also default to CT. And then everybody else, or if they have a focal neurologic deficit, they go to CT. And for everyone else, for any other risk factor, they are first screened with plain radiographs. So I think you can forward to the end.
All right, fantastic. If all of our speakers wouldn't mind taking themselves off of mute, we do have a few questions, and I will try to get them in order. So the first question comes from Camille Storm, and it says, recently the FDA approved the use of blood tests to evaluate mild TBI. Does this work for pediatric?
Here, so yeah, this is Nate Kupperman, and I'll take that. So the vast majority of children that come in with minor head trauma, they're not getting blood testing, right? We're just evaluating whether they need CT or not. So I would say for the great majority, I wouldn't. For those that you think might be concussed or those that you are seriously considering CT, there may be some utility, but there have not been wide-scale testing of those screening modalities and its accuracy against CT in children.
Thank you, Dr. Kupperman. Our next question is, what do you mean by cost of C-spine immobilization? Is that the cost of the device?
So in that those 1993 estimates, it was the cost from the procedure, the build procedure in the field, all the way through to imaging in the emergency department. And they averaged the cost because at that time CT was kind of entering as the main modality, so it was an averaged cost. So the whole process, that inclusive of the device in the field and the procedure in the field to the imaging clearance in the ED.
Thank you, Dr. Leonard. The next question is regarding prospective cervical spine P-CARN variables, a number of factors were associated with odds ratios of greater than 1. Is there a thought to develop another model?
Yeah, hi, I'll field that one as well. So prospectively, and the publication is forthcoming, that is the goal, is to conduct a large 15-center prospective observational study, because in that 4-center study, we were able to identify other factors that perhaps perform better at both predicting those that have injury and also identifying a set of children that don't need an intervention. So yes. On the other hand, if we're talking about the literature that we have available to us on this date, the retrospectively identified risk factors were the most robust in terms of how many patients we have in the analysis. And yes, when you looked at, there were a lot of, in bivariable fashion, risk factors. The model we present are the ones that together in aggregate perform the best. So in other words, there might be one factor that's a proxy for the other, but altered mental status performs better than another marker of substantial head injury, signs of substantial head injury, meaning like a skull fracture. The altered mental status is the better predictor. So we would still default to that multivariable model.
All right, fantastic. In the essence of time, we're just going to go ahead and end the webinar. And thank you to our 3 amazing speakers. If you do have individual questions for them, they were able to provide their email address. I'm sure they wouldn't mind receiving those questions from you guys. The actual webinar has been recorded and will be made available on our EMSC site. That website, along with the survey regarding the actual content, will be sent out to all those that logged in. And if you are logged in as a group, i.e. watching it in a conference room with several people, just make sure that you do forward that along. We had several questions regarding that because those logins were individual to each learner. If you have any questions, please feel free to email me. Otherwise, thank you all for joining, and you all have a fantastic rest of your afternoon. Thank you.
Great. Thanks, everybody.
Thank you. Bye.